Hi class, it's Dr. Lindner. What we're going to be looking at now is blood pressure. So let's look at what's involved in regulating blood pressure. Maybe there's some hormones involved, the endocrine system, uh, the neural system. So let's take a look at all the different structures involved. So here at the bottom, there's some homeostasis, right? We have balanced blood pressure, but something happened which created some sort of stimulus that created a rise in pressure. Something happened that created a rise in pressure. And as that increased pressure is traveling through the blood vessels, we have some receptors that can detect that. Those pressure receptors are called baroreceptors. We've heard meteorologists talk about barometric pressure. So, baroreceptors are receptors that we have in major blood vessels of the body. One in the carotids, right before the brain, and one in the aortic arch near the heart. So these two areas are detecting what the blood pressure is like. And it's going, hey, we've got high blood pressure. So it's going to send that or those signals to these sensory signals, these afferent sensory signals, and it's going to go to the cardioinhibitory center, which is in the neural system, to inhibit the acceleration. It's saying, hey, let's take the foot off the accelerator and let's put it on the brake. All right. So that's going to be taking the pressure off the accelerator is decreasing sympathetic impulses. When you decrease the sympathetic impulses, you decrease the heart rate and you decrease the rate of contraction. When you decrease the heart rate and you decrease the contractility, you're decreasing the cardiac output, right? How much blood it's ejecting out, which will decrease the pressure. At the same time that you're decreasing sympathetics, if you're decreasing sympathetics, you're increasing parasympathetics. Now, when you decrease sympathetics, when you're decreasing sympathetics, the blood vessel, the diameter of that lumen opens up. So it vasodilates. So the blood vessel diameter increases. When that lumen becomes smaller, that's called vasoconstriction. When it opens and gets larger, it's vasodilation. When it constricts, blood pressure goes up. When it dilates, blood pressure goes down. When it dilates, there's less pressure because there's less resistance, right? The blood is not hitting the walls in such a constricted area. So we have decreased resistance and decreased cardiac output. Both of those are enough to balance out the blood pressure. Now, on the opposite side, the opposite thing can happen where there could be a decrease in blood pressure. Same thing, the same baroreceptors in the carotid sinuses and the aortic arch detect that. And now it's going to send signals to the sympathetics to speed up, right? To stimulate, not to inhibit, but when the sympathetics are stimulated, your heart rate and increased contractility go up. And look at the lumen of the diameter of the blood vessel that constricted. When you get constriction, you get increased resistance. When you increase the sympathetics, your heartbeat is going to increase. You get increased heart rate and increased contractility. That's going to increase the cardiac output. So you have increased cardiac output, increased resistance, raises the pressure back to normal. Now, there's another system that can do this that involves, look at on the left, it involves the liver, the lungs, and the kidneys. The lungs, the liver, and the kidneys are involved in regulating your blood pressure and the heart. Most people don't consider that, but let's understand the mechanism. So the liver makes angiotensinogen. Remember, anything that ends in -ogen means it's inactive, right? Like glucose, when it's stored, it's glycogen, inactive sugar. Glycogen can be activated to glucose. In the stomach, we have a digestive enzyme called pepsinogen, which breaks down protein. It's just inactive. Okay, so angiotensinogen is inactive. Angio means blood vessel, and tensin sounds like tension. Tension of blood vessels. Tension of blood vessels sounds like blood pressure to me. So the liver makes angiotensinogen. The kidney makes renin. What is the kidney called? The kidney is known as renal. The first three letters of renal, R-E-N, renin. So the kidneys make renin. When renin bumps into angiotensinogen, we get angiotensin 1. Now, if there's an angiotensin 1, it's safe to assume that there's going to be an angiotensin 2. But what is it that converts angiotensin 1 into angiotensin 2? Well, it's called angiotensin converting enzyme, known as ACE, ACE. Now, ACE is made by our good friend, the lungs. So the lungs make ACE. The lungs make ACE, angiotensin converting enzyme. That converts angiotensin 1 into angiotensin 2. Now, once you have angiotensin 2, this is where a lot of the magic happens. Angiotensin 2 is going to constrict your blood vessels, which increases blood pressure. Angiotensin 2 is going to stimulate the release of aldosterone. Aldosterone is the hormone that allows us to hold on to sodium. And we know when you hold on to sodium, hold on to chloride, sodium chloride is salt. If you hold on to sodium, which is minerals, minerals and water always go together. So if we're holding on to sodium, you're going to hold on to water. What angiotensin 2 also does is it increases your salt. It increases your salt cravings. What angiotensin 2 also does, what happens when you eat something salty? You get thirsty. So it increases your salt cravings, and then you drink water, you get thirsty. Aldosterone holds on to the salt that you ate, okay? And what angiotensin 2 also does is it stimulates the release of ADH, antidiuretic hormone. So the salt that you ate is retained by aldosterone, and the water that's retained that you just drank from being so thirsty is held onto by antidiuretic hormone. So you have increased salt, increased water, vasoconstriction, all of those things increase your blood pressure. Okay, so when people have swollen ankles, they'll say, oh, they're retaining water, let's give them a diuretic. If they give them a diuretic, they lose water. If they lose water, they lose the minerals, they lose salt, and blood pressure goes down. Or some people take an ACE inhibitor. If you take an ACE inhibitor, that means you can't convert angiotensin 1 into angiotensin 2, so nothing below this line takes place. Again, another way of decreasing blood pressure. Diuretics are kind of dangerous because when you lose water, you lose minerals. And one of the dangerous ones to lose is potassium. When you lose potassium, you lose magnesium, you lose other minerals as well. And people often get these, what they call ventricular ectopy, where the heart just stops beating and they just die without warning from these diuretics. So they try and make what's called potassium sparing diuretics. They're just not as effective, but they do decrease the loss of potassium. But again, they're just not super effective. So some of the hormones that affect blood pressure, the heart makes ANP, atrial natriuretic peptide. So these are going to be hormones that decrease blood pressure, atrial natriuretic peptide. So the heart itself can say, hey, the blood pressure is too high, let's get rid of sodium. If we get rid of sodium, we'll get rid of water. You get rid of, some salt and some water, then the blood volume decreases and the pressure declines as well. Then we have nitric oxide, that's a vasodilator. Nitric oxide can come from an amino acid called arginine. So from this amino acid arginine, our bodies can make nitric oxide. Happens to be high in watermelon. Arginine happens to be high in watermelon. So it is a brief but a potent vasodilator. Nitric oxide, this is what they use to treat erectile dysfunction, like Viagra. Okay. Histamine can also dilate blood vessels and thin the blood. Prostacyclins thin the blood. So when you thin the blood and it becomes thinner, blood pressure decreases. Alcohol as well. Alcohol causes blood pressure to drop by inhibiting anti-diuretic hormone. We know that blood pressure, for years, was said 120 over 80 is normal, 120 over 80 is normal, but it should be less than 120 and less than 80. Okay. The pressure of the blood in the vessels when the heart beats, that's systolic pressure. And the pressure between when the heart's relaxing, that's diastole. So systole over diastole. If it's between if the top number is between 120 and 139, and the bottom number is between 80 and 89, that's pre-hypertension. And if it's over 140 over 90, that's high blood pressure. Okay. And again, when blood pressure is taken, the patient is seated, they're not talking, they're relaxed, the feet are flat on the floor, it's skin contact, the cuff goes around the arm with the sensor in the front, and the arm is stabilized. The patient is not contracting their muscle. The arm is not hanging down either. It's got to be perpendicular. So you can see my fingers are here underneath the elbow, stabilizing it, and the diaphragm of the stethoscope is here, and my meter, I'm evaluating and watching it here, and the trigger to release the pressure is underneath. It's a little bit more of an updated sphygmomanometer. Okay, and you compare left and right, and always do it a few times. Don't just do it once. You have to double check and sometimes triple check your numbers. And you don't want any noise or music in the background. You don't want them talking, just nice and quiet. And you want consistency as to the time of day that you check it. Now, some people start low in the morning, and as the day progresses, goes up. Some people start up in the morning, and as the day progresses, goes down. That's information that you would give your primary or your cardiologist to know, are you a riser or are you a dipper? Risers and dippers get different medications if it's a crisis to manage. With me in my office, we look at high blood pressure primarily as an inflammatory biomarker. And if their blood pressure is high, we figure out where the inflammation is and we try and deflame them and bring the inflammation down without drugs, without stuff, just holistic measures first, using exercise, using foods, and certain supplements to bring it down. If with a genuine effort, with all of those things that don't work, with lifestyle changes in diet and exercise and supplementation, then we go up the next line of defense towards pharmaceuticals. Okay, that is the right approach to do things. Okay, you can see that I went from checking her right arm, same thing, checking the left arm and comparing our numbers. If there is a 10 millimeter difference between left and right, the chances increase by like 15 to 20% of some sort of cardiovascular event. Okay. If there's an imbalance between left and right, it also indicates that there could be some sort of cerebellum imbalance between the left and right cerebellum. Could also be an issue because that is what has to function to equalize pressure into the extremities. Just some food for thought. And all the different pulses we can palpate. Palpate means to feel the strength of pulses in all of these areas. Um, Temporal artery, most people don't pay attention to. Very important with smokers because many people, many smokers get severe headaches and can go blind from a condition called temporal arteritis. When they have temporal headaches, it could be an issue with that temporal artery, and there's branches off of it that feed the eye. So taking good case history is always very important. Where the sternocleidomastoid is, that's the common carotid artery. And remember, every time we see the word common, it's safe to assume that it's going to divide into an internal and external artery, and it does. For blood pressure, the brachial artery. When we feel our pulse, it's usually the radial pulse. Here's the femoral artery behind the knee, popliteal artery. Right behind the medial malleolus, the posterior tibial. And right between the great toe and the second digit is the dorsal pedal. This one's kind of important. We want to feel a pulse down here, especially in men. We want to feel a pulse here, especially in men. When these are weak, it typically leads to erectile dysfunction, low blood supply. Often you'll see hair on this part of the leg, but then down here, no hair at all. Okay, that's due to poor blood supply being ejected and poor perfusion down to the lower extremities.